and she's our geneticist.
Genetic. That's okay.
Oh, genetic counselor, and she's going to talk about HCM and the CV Genetic Clinic.
All right, so I'm just going to do a review of month one because we're getting kind of frequently asked questions a lot. So some things I'm seeing both in emails that are sent to me or patient charts that are routed to me through Epic. So I had a case actually, and this is probably the easiest way I could find to explain it to everyone, is I called a patient named Carol, and we walked through kind of what the clinic is like, and a lot of her questions were the same questions you all have been asking. So her first thing was she's 78 years old. She's had cardiomyopathy forever, as she said, and I was talking to her a little bit about her family history, and she said, well, one of her sisters has had an abnormal heartbeat in the past, but it really got better, so she's never seen a cardiologist. And she really wanted to know, is this helpful for me? And she said, I've never really heard of genetics. I don't really know what this will be like. And she said, well, first of all, I'm 78 years old. And this is probably the number one question I've been getting. And we want to see people regardless of age because we're less concerned about the 78-year-old and more concerned about their children or grandchildren or other family members. So for her, her HCM has been around forever. She's, been managed really well, and she didn't have a lot of concerns. So her first thing was saying, him, 78 years old, is really going to benefit me, and the answer is always going to be yes, because she has those relatives. Unless every person in her family has passed away and she's the only living person, that's really the only case where I wouldn't be wanting to see someone. Go next. All right, and then she said, well, I've had this cardiomyopathy forever and it's really well managed, so I'm happy with my treatment, I'm happy with my cardiologist. Do I still need to come in? Do I still need to be seen in your clinic? And that answer is going to be yes. And that's actually even better because you really want someone to have had this heart condition for a while because HCM is something you're born with. So from day one of life as an infant, well actually even in mom's tummy say, you're going to have this heart condition. So, given that it's been present since infancy, you would expect her to have it for a long time. And just because she's now, symptomatic, maybe in her 60s or 70s, does not take away that this could have been something she was born with. So that's really the key, and it's really the key to finding those family members because it could be running in the family even if people aren't presenting as symptomatic, just because we know it's a really variable condition. So even if they developed HCM at a young age and they're really happy with their care, it's still really important because we're worried about screening their family members. So for her, most likely, we'll come in, we'll talk to her about testing, send her back to her doctor if that's what she requests, but really getting those relatives to come in and meet with us is the key. All right. And then her next fear is, well, testing is so expensive. I've heard of genetic testing. You hear these horror stories of people paying $4,000 out of pocket for a test, and she didn't want that. And the main thing is testing has changed a lot even in the past year in terms of what we know and what we can do. She particularly had Medicare, so for her, testing is going to be covered in full. The only criteria for Medicare is, do you have a diagnosis of hypertrophic cardiomyopathy or HCM, which she did. So she meets their criteria, and Medicare is an all or nothing kind of insurance company. So they'll say, yes, I'll pay every cent, or no, I'm not paying a dime. And so for her, since she has that diagnosis, it's going to be free, with a few rare exceptions. For people without Medicare, it's a little more complex, but we offer prior authorization as well for those folks. Most patients are going to get tested. Most patients pay well under $100. We also do not surprise bill anyone, so they're never going to owe more than $100 without knowing about it up front. If they feel uncomfortable with even $100 out of pocket, we will do a prior authorization. All right. And she said, her main concern was, hey, does this impact my care? And I said, no, but tell me about your family. Do you have, sisters? And she's like, oh yeah, I have 3 sisters. I'm like, do they have kids? And she's like, oh yeah, each one of them has 2 or 3 children. And I said, well, those are the people we really worry about. Are they, active? Are they in sports? Are they in any, things that would be taxing their heart? And she had some baseball players, some wrestlers, different things like that, and her grandchildren, or I guess her nieces and nephews. And so she said, well, I really want to know that for them. And I said, well, it sounds like you would really benefit from this because we're worried about, your family members. We're thrilled that your cardiomyopathy is well managed. You've been living with this for a long time. You understand it, but your relatives may not, and it could really impact them. Her sisters would be a 50% chance to also have the same thing in most cases. But our focus, what we really try to drive home is the family aspect. So if that particular patient has any relatives, we do not care if they're 99 years old or 15 years old, we're going to want to see them for their relatives. All right. She said, okay, well, now I'm interested, so how do I do this? And really it's just a simple blood draw. We typically draw 1 to 2 small tubes of blood, and we're going to have saliva or spit kits in the next month or 2. Depending on how quickly they launch, but they are coming for cardiology. And it's not a cheek swab, so I've had a couple patients call and get upset when I tell them, no, you'll actually be spitting into a fairly large size tube. It's a little gross for like an elderly lady. They don't really appreciate the, hocking into a tube for a while, but we get there. I always say, you can do the blood draw. It's actually a lot quicker and a lot easier.
Did you just say hockey?
I did, yes, because they literally do have to it takes because we need roughly like 1.5 inches of saliva, and it takes about 20 minutes. So because you don't really, and bubbles don't count too, so they get really discouraged when the bubbles are filling up the tube, but the actual saliva line is low. So it's not a fun thing to do. All right, so what do we do in the visit? So my piece is really going to be the family tree, because again, we're worried about the family members. For most of these ladies who come to us, they're going to be well managed with their doc. We're going to make sure they're happy with their care. If they've been seen a few different doctors and want to establish care with us, we can do that. But really, we're worried about getting their family members in and getting their relatives screened. So, we can recommend screening for people if they haven't done the recommended screening intervals yet, and then explain the insurance coverage as well. We typically do testing on the same day. So we had our first clinic and we tested both patients on the same day. So, yeah. All right. Oh, this is my old slide. Okay, well I had a pedigree for you guys, but I didn't pull it up.
Okay.
But anyway, Dr. Robertson doesn't even know this. But so we saw a patient in Vanda. She was 66 years old, and we actually scheduled echoes and EKGs for her, one of her daughters already, and then also her sister, to get them screened. So she presented with pretty classic HCM on her screening from an outside physician, I believe. And so we've been following her. And so our very first clinic, I talked to her daughter the same day that we saw Vanda, and I talked to her sister the next day. So they get a gold scar for being a good family with their screening. And they actually said her daughter had mitral valve prolapse when she was a teenager and when she was playing soccer, and she had a couple episodes of syncope and possible fainting, and they attributed it to the mitral valve prolapse. So now we're kind of wondering, could this be linked? So as I talked to the daughter on the phone, we kind of got all this other information, and she said, yeah, it was pretty bad, I guess, in soccer season. And she didn't want to tell her mom so much because she didn't want to stop playing soccer. So, these are the family members we want to see because her daughters have children. And we talked about, hey, your mom's getting tested. We'll know her results in about 3 weeks. But if in the meantime, if you want to come in, I recommend the daughter come in sooner rather than later, since she had symptoms at some point that may or may not be that mitral valve prolapse. But then she has another daughter and her sister, and I said they can come in or they can wait for those test results. 2 of them wanted screening, the other daughter is waiting. So, all right. So other questions, anyone? And I had a cat video for you this morning, but I'm sorry, it's gone.
Oh, it's gone.
Just trying to brighten up your Monday a little bit with cats. But yeah, that's kind of a rundown. So I don't know if that answers some of the questions we keep getting. The main thing I keep seeing is age. If they're 87, 97, do they really need this? And the answer is always going to be yes because of their family. I've talked to one gentleman and he said, hey, my relatives have all passed away. I didn't have any grandkids, any nieces and nephews. Do I really need to come in? Probably not, because then we can't do the family tree aspect. There's not really a lot of people to go hunting for. Most people are going to have a family, and that's who we want to, go after and make sure that they're being managed, that if they need activity restrictions or if they have heart enlargement and they're not showing any signs or symptoms yet, just because that the first and only symptom can be sudden cardiac arrest, and we want to avoid that. Does anyone want to review HCM at all? Or any other questions?
On your family tree in the handout.
Oh yeah, you can see the family tree in the handout.
So when you have like a line through the squares and the circles, and then suddenly you don't have any, so only you don't have a line, are those people who have the disease? I'm just trying to follow with this.
Oh, yeah, okay.
The cat's
So-
in there too, I think.
I saw the cat.
Oh, yeah, the cat is in there. So the cat like schleps over a piece of Monday, so. So the lines through are gonna be that they passed away. So anyone that's deceased is marked through the slash. The black triangles are gonna be, so if you look at Vonda where the arrow is, the black half triangle is gonna indicate that she has the condition. To date, none of her family members have been diagnosed with HCM. So right now, she's the only person in her family that has that diagnosis. The main things is we kind of noted all the other heart issues in the family. The key thing with Vonda, where we're really suspicious for it being hereditary, is she had an uncle that passed away at 42 from an unexpected heart attack. So we're thinking she has a fairly good chance of us finding something. And her daughter Melissa, who is the 13-month-old boy, is the one that's going to be seen. So, yeah. Does that help at all? And boys are squares, women are circles.
Of course.
The boys do not appreciate it when I say, hey, the boys are squares, so. Very offended.
Super cute.
Sarah, yeah, I know that you were in attendance at the Women Heart Expo, the Love Your Heart Expo. Did you find opportunities there with people who came up with stories or whatever?
So we had one that was not HCM, that was a good case, if you want to hear about that, that's a fun one. But the other, I talked to one other person that just had a brother that passed away very unexpectedly and very young in the family. And I just recommended, hey, let's come in and do heart imaging. They didn't know why the heart attacks had happened, but they'd never seen a cardiologist, and they were just kind of there to learn more information. So we did recommend she come in to see a cardiologist and get some preliminary, imaging and studies done to see if we can make sure her heart is doing okay at the moment. And I just let her know that, if it is something that's running in the family, it can present kind of at any age, and there's not any triggers that really cause that typically, so it can present at 45, which I believe is the lady's age when she talked to me, or it can present at 80, anytime between there, really any time in that lifespan. So I said, just because you have a one-time cardiac evaluation doesn't mean it won't happen for you, but at least you need to get set up and have your care team in place so you can be monitored over time and make sure that heart doesn't show any differences or any conduction differences. So just recommended screening for her. The other lady I saw, do you want to talk about my non-HCM lady? Okay, she was a good one. So there was a lady who came up to us at the heart event who had genetic testing through a different doctor, so not a cardiologist. I don't know if you want me to say where they were from. Okay. So anyway, they had this testing done, and all genetic testing is really not created equal. So our genetic testing we do has guidelines. It's proven. Insurance will cover it. It's a big deal for our family members because if we find it, we will do things to change those family members' management. Unfortunately, she had a test that would not alter her management, and she came up and said, hey, I've been wanting to talk to someone about, this testing I had. And we reviewed her family history, and she did have a brother who passed away in his 40s of a heart attack, very unexpected. And she said, I've been seeing my doctor for a while. We did run a genetic test. I was found to have this, and I feel like I've been given a complete death sentence. I feel like I don't know what to do. I'm scared. I'm losing sleep over this test result. Can you help me? What do you recommend? And unfortunately, I was able to sit down with her and talk about the testing that she had, and it's a thing that has been shown back in the 80s to cause heart attacks, and it improves your health. It's called MTHFR. Anyone ever sees MTHFR, I'm more than happy to field all questions about that. So with this MTHFR testing, which you'll see a lot of patients actually get it, and a lot of patients have it because 30% of all people carry a change in the MTHFR gene. But it's really a benign change. People, have been shown to say, hey, this was linked to heart attacks, or hey, this is linked to coronary artery disease, and that's actually been disproven over the years. So they don't know, some clinic offices still test for this, and they'll find this result, and they think it's really important. So for this patient, she thought she was given a death sentence when really it doesn't mean anything. So she was, taking all these vitamins, hoping that it would improve her heart health, hoping that she would not have the history their brother had. And I said, well, have you ever seen a cardiologist? And she said, no. And for something like HCM, there's no way we would have known if she had this condition because she's never had echoes, she's never had an EKG, she's never had any kind of the testing that we would typically recommend. So we did recommend she follow up with us. I said I'd be more than happy to, give her guidelines and kind of review the testing that she already had just because some testing is not so helpful, and that was one of the not so helpful tests. And she was just extremely, discouraged by everything. And I said, hopefully this will help you not lose sleep anymore, because that's not a for sure thing that you're gonna walk down the same road your brother did, but you need to get some proper evaluations of your heart. Because the testing that she had would not tell her about anything that we test for in our clinic. So that's my kind of caveat. Some genetic testing is really wonderful, and some genetic testing is vastly unhelpful.
So one medical thing that I guess I would like to stress about hypertrophic cardiomyopathy. First of all, what's the hallmark of hypertrophic cardiomyopathy? What are we looking for in people with hypertrophic cardiomyopathy? What does that mean?
Thick heart muscle.
Yeah, so basically it's hypertrophy, right? So we're looking at hypertrophy of the ventricle in an abnormal pattern. It causes either hemodynamic or no hemodynamic ramifications. It can cause arrhythmic ramifications. It can cause heart failure ramifications, a lot of different things. The thing we're obviously concerned about is that we want the patient to feel well, but we also don't want them to die early. And I think one of the key points that Sarah made was the clinical manifestations and presentation of hypertrophic cardiomyopathy can be very variable in an individual. So the timing isn't predictable. In other words, it's not going to be when you're 22, it's not going to be when you're 32, it can be at any point along the spectrum. And as well, those patients may have symptoms early, they may have nothing. So you may be 87 years old and have lived with hypertrophic cardiomyopathy and not had sudden death, but that does not mean that the offspring aren't at risk for some level of sudden death. Family history is an important aspect of that, but it's not the only aspect to it. So I think that's one of the reasons that we're going through all this, is to understand that even though somebody hasn't had sudden death, obviously they're in a clinic, they haven't had sudden death and not been resuscitated. So, but even if they have had sudden death, that doesn't mean that family members are at risk for sudden death. And that's logistically, my concern is there any concern about calling patients from your own pods and having them understand what we're doing as far as referring these patients? Because we have this list of patients, right? And so they have some ownership by physician and nurse groups, right? And we really think that it's probably the best interaction to have either the physician or the physician's nurse call them and say, we're taking care of your heart, and we understand that you have this issue, and we have a specialty clinic, and this is what we'd like to refer you to as your primary cardiology group. So is there any issue with that, or lack of understanding about what to tell them, or how to deal with that, or concerns in general, or anything like that?
And one thing I was thinking with that, so if anyone is having, concerns about addressing that, I think one of the things is just to be honest, say, hey, I'm calling you about this condition, I don't really understand it, and you need to see a specialist for this. It's unusual. You have a family tree, but, we're a little less familiar with this heart condition. We're happy to manage your symptoms, they're well managed especially, but I think just in being honest with the patient, if anyone has concerns about that, is your uncomfortable level with, giving those results is exactly why we have this clinic in place. So I think just saying, hey, you know what, this is confusing. If you want more information, I will connect you with Sarah. She'll explain anything. But otherwise, we have this specialty clinic because it is a hard thing to understand, and we do need specialists in this. And I think just being open and honest about your own, things I don't know, things I do know, and saying, hey, you know what, if we all knew this information really well, then a specialty clinic would not exist for this condition. And that's why we need it. So I think, kind of going that route as well. Just being like, hey, we understand how to manage your, the symptoms and the medications you're on, but in terms of this heart condition, it's pretty unusual and, somewhat more unusual. And we have a team now in place where we can take care of everybody. So I don't know if that'll help. But at least that's how I say it when I don't understand something. Like, hey, I'm sure someone else knows this a lot better than me. I will let you talk to them.
I think it's important for the physicians and nurse teams to make that contact because you're the ones who know those patients. I know often phone nurses will get a call about it, And, you know, I still think we can speak on behalf of the physicians and say, you know, what, these are the reasons that we want you to see Sarah and Dr. Robertson. But I think that the calls need to come from the physician-nurse team so the patients feel confident that they're just not getting a cold call from somebody who's trying to sell them something. You know, and they don't know Sarah yet, and once they do know Sarah, then they'll have complete buy-in because she is the expert alongside with Dr. Robertson. So I think that's why we made the decision to have the physician-nurse teams be the ones to address and make the calls to the patients to introduce this to them. So if you have any reservations about that, you need to see me or Dr. Robertson or Sarah or Denise, because we need to make sure everyone understands the reasoning behind having the nurse physician teams make those calls.
You know, honestly, I think it goes beyond that. Okay, I think so. I don't know that it's suggested. I think if you have a specialty clinic and your patient has this problem, it would be now considered our standard of care to make sure that those patients get into the specialty clinic. So it's a responsibility of each team to make sure that happens. So if you have a hypertrophic cardiomyopathy patient that's at risk, or some family members at risk, and you choose not to call them or just be passive about it, that's as active as calling them. I mean, that's a decision. Because we have this clinic now, and this clinic is designed to try to stop any adverse outcomes. So it's not really even I'm not even sure it's a suggestion or a, you know, it's a subtlety. It's really an objective responsibility that everybody has to make sure that happens.
It's our standard of care.
It is our standard of care now because we've developed this and we have amazing up here, and she's amazing. So we have all kinds of avenues to make sure that people are educated on their problem. And I can just tell you that there's, you know, the docs in general are not going to understand genetic testing for these different, you know, issues. They're not going to understand, you know, kind of some of the nuances of it because that's not their focus. But that is our focus. So that's why we have a valve clinic. That's why we have all these things. You know, I think it's our responsibility to make sure as we go forward in our current time, we can get these patients channeled to these clinics that they deserve to be in, because that's what we're going through all this effort. We want to give them the absolute best care. We want to be really efficient. And you know, that's going to be a little bit of a culture change as we go through, in that our patient population is going to become a little bit siloed or segregated into these clinics for a good reason. The care is going to be more efficient. So a patient may have coronary disease, let's say 10 years ago, and they get stenting, and they did fine, and they haven't had any symptoms for 10 years, and they keep following with their primary cardiologist, which is great. But they get an echo, and last year their wall thickness was 2.1 centimeters, and they feel a little short of breath. That's a different issue. So that scenario needs to be addressed in the appropriate clinic. And it might be that their primary problem, because maybe taking statins and exercising and all the other things, their coronary disease is relatively a quiescent issue, right? So they don't really need that attention, but maybe their grandkids need some attention because one of them's going to be in middle school and playing on the basketball team, and we don't want any disasters. So I think really it's not even a suggestion. It's actually an obligation that we all have, and it should come from those primary teams so we all feel like we have ownership in where those patients are going. The more educated we can get everybody about all these little subspecialty clinics and all these interesting things that we have going on, the more enlightening it is for us, and then also better for the patients. The more we get everyone involved in specialty clinics, so the more, if you have interest in any of these clinics, if you have interest in, you know, I have interest in valvular heart disease, I have interest in this, I have interest in that, you know, I encourage everybody to get involved in it, because obviously the more interested you are, the more ingrained you are, the more valuable you are to the system, the more valuable you are to the patients. You know, that's kind of one of these growth things. So it's going to be important that we have general cardiology and take care of all the background, but we really have to be specialty doctors, and we have an obligation to make sure our patients get, you know, care. We might as well just go ahead and lead the whole process and be one of the few places in the region or the United States that really has all these things ironed out and really knows what we're doing. There's no reason to wait for somebody else to demonstrate that they can kind of organize something like that. And I think then, you know, you'll find that there are little pockets of genetic mishaps all over the place. And some of these patients are being followed with no answer. They've been identified, like Sarah's little example, been identified as maybe having a problem, and then no one does anything about it. And that's probably more distasteful than it is to not test. Because if you're going to tell somebody they have an issue or identify some issue, but either you don't know how to treat it, or you're not interested in figuring out how to treat it, or you've not educated them on the fact that this is what it means, then it's really a real big challenge for the patient. Not probably not fair in a certain sense, because we all sit here and don't know what's going to happen this afternoon, right? So that's part of life. Some things you can help yourself with your own foresight. So I think I would say it's really an obligation that we have, because now it is the standard of care. We're putting a lot of effort into all this stuff, and want to make sure that it not only just does well, but that we do the right thing for the patients that are walking around. And the last thing I'll say is it's amazing when you look through and you would think, okay, well, I don't know how many hypertrophic cardiomyopathy patients we have walking around. Well, we have a lot of patients that meet some screening criterion for hypertrophic cardiomyopathy, which at the very level, if you're sitting there and you're either a mom or a grandmother, I guess Doug would be something with father in this. But at any rate, if you're in that circumstance, you can just see how you might respond if you maybe had a genetic predisposition or had a genetic alteration that would put your grandchildren at risk or your kids at risk. You would definitely want to know and make sure they get the right care. Make sure somebody's following.
Can you just review real quick the criteria, like millimeters or centimeters of the wall thickness, or if they do have LVA, that are.
Well, it's really simple from a referral standpoint. Okay, from a referral standpoint, people that have more than their basic LVH, a wall thickness of 1.2 centimeters with long-standing high blood pressure, that may not be anything, okay? Because that would be something relatively common that we see. Okay, but then you take the same patient and they have relatively mild hypertrophy, they feel a little short of breath, or they've had 4 episodes of syncope that nobody can describe, or they've had somebody had sudden death in their family. So all of a sudden you start wondering, is there something happening here? When was the last echo did they have any hypertrophy then? So 2 years ago they had no hypertrophy, now they have some. Or, those things. So when you talk about regional wall thickness, that's one aspect of hypertrophic cardiomyopathy. It's important to me if I'm in the clinic because regional wall thickness may help me predict, at a certain level, may help me predict adverse potential. Okay? But it doesn't necessarily tell you that is going to be the case. So somebody can have severe concentric hypertrophy and not have sudden death, and a lesser degree of hypertrophic cardiomyopathy and have sudden death. So I think from a referral standpoint, the interesting things are just to have your ears up, right? To be educated. Because that's what I'm saying, being integrated in the things that are important to help your patient. And that's more than know that it exists. It's understanding that it's hypertrophy of the ventricle, that it has a risk to family members, and that the things that you think about are people that are starting to have symptoms related to something with their hypertrophic cardiomyopathy. That may be dyspnea on effort, that may be chest discomfort, that may be symptoms or signs of somebody living with quote-unquote heart failure at some point, whether or not they've had syncope, so now you look in their chart, you see, well, after they've passed out 4 times in the last 3 years, and the neurologists say it's not a seizure. Well, what the heck is it? That you want to know what that is, okay? And then, if you say when they come in, just out of curiosity, everybody in the family's doing good, well, I've had this horrible thing happen. My grandson lives in Florida and just had sudden death. So those kind of things are all important. So for you, as far as referral, it doesn't really have to be, you don't have to drill down. But you have this, it would be nice if you had some working concept that maybe this is a patient I'm a little bit suspicious about. We'd much rather look at somebody and identify that they're okay, they're safe, and then they can go on about their business, rather than overlook somebody. Because you're looking for a needle in a haystack in a way, right? So we have thousands of patients, but we don't have thousands and thousands of hypertrophs. But they're in there, and the family lineage is the concern. So someday when we have time, I can give a lecture on hypertrophic cardiomyopathy and all the nuances. But that really right there gives you what you need to know.